Hi, everybody. I just want to welcome you all to our Outbreak Preparedness 101 webinar. The webinar is going to be hosted by Sharon Ward-Fore. She is an infection preventionist in the Chicago area. We're very lucky to have her here among so much talk about this pandemic, right? And what to do in your healthcare sites and wanting to get educated and what is the right source of education. We want to have a centralized way for you to get this information, to be prepared, prepare your facility as an infection preventionist. We're very grateful to have Sharon here, and before I end up turning it over to her, I want to make sure we talk about what is the Metrex mission, vision, and belief as we basically who we are as a company. So I won't read through all the slides, but I want to focus on a few major points, which is our vision being a world without preventable healthcare associated infections. It's a really hard thing to have a vision towards, considering the current situation, but that's what we strive for every day, day in and day out, as we work to protect those in the healthcare setting, whether they're professionals or a patient, right? So that the focus can be on the most important thing, which is always to get that patient better, focusing on the pillars, which are our people that are working to build this webinar out for you. The people that are supplying these products, right, that you need in these settings, as well as something that's very important to us is the partnerships that we have with infection prevention, the partnerships that we have with our distributor partners, partnerships that we have every day to basically make this vision come into fruition. So with that said, very excited to be partnering with Sharon here as she speaks on outbreak preparedness. So I'll go ahead and turn it over to you, Sharon.
Thank you, Denise. Hello, everyone. Thank you for taking the time to view this webinar. The goals of this webinar are to provide a basic understanding of what COVID-19 is, how pandemics work, how COVID-19 spreads and how to prevent it, and also how to prepare your facility, staff, and patients. And then we've also listed some resources on one of the very last slides for you to take a look at and hopefully find valuable. So COVID-19, what is it? Well, it's a respiratory illness caused by the virus SARS-CoV-2 that can spread from person to person. The first US case was reported on January 21st of 2020. This is a new or novel coronavirus that was first identified during an outbreak in Wuhan, China. Now, there's some data that suggests the first case in China was reported on November 17th of 2019, but that case is not thought to be the index case or case 0. So COVID-19 is a beta coronavirus like MERS and SARS, and all three of these viruses have their origin in bats with transmission to humans. It's an envelope virus, meaning it has an outer layer typically composed of lipids, which are sensitive to desiccation or drying, heat and detergents, making it really pretty easy to kill with disinfectants. Much is still unknown about COVID-19. So why is it a pandemic? Well, the World Health Organization defines a pandemic as a worldwide spread of a new disease. What they mean are cases and community spread have been detected worldwide, therefore now it's considered a pandemic. And the World Health Organization declared a pandemic on 1/31/20, really about 1 month after the first US case was reported. So this is the first pandemic known to be caused by the emergence of a new coronavirus. Historically, there were 4 pandemics that have been caused by the emergence of a novel influenza virus. Now, those 4 influenza pandemics are the 1918 influenza pandemic, which killed 40 to 50 million people, the 1957 to 58 H2N2 avian flu pandemic, which killed 1.1 million people, the 1968 to 1970 H3N2 avian flu variant, which killed 1 million people, and our most recent 2009 H1N1, the swine flu, which killed 200,000 people. So most, if not all, of our guidance about pandemics was learned from experience with influenza. And when you look at this timeline, you can see that influenza has been the primary cause of most pandemics. And you can also see, looking at this, that we've learned something from each pandemic, especially the 1918 influenza pandemic. So why is it a pandemic? Well, based on previously studied influenza pandemics, we know that pandemics of respiratory disease follow a certain progression. And they tend to be somewhere along these 6 steps. And you can see these graphs sort of represent the phases or the steps of a pandemic. And the first is the investigation phase. And this is where the virus is identified and we have information that implicates its spread to human health. The second stage is the recognition phase, where we see the increased number of cases or clusters, and we see an increased potential for person-to-person transmission. The third phase is the initiation phase, and that's where we've seen both efficient and sustained person-to-person transmission. The fourth, or the acceleration phase, is when this new virus has found its home in susceptible people. And it's at this point that public health may take measures such as closing schools, encouraging social distancing, offering antivirals or vaccines if available. And I think right now in our world, we're in the acceleration phase in a lot of locations. One other important step is the deceleration interval. And this is where there's the increasingly consistent deceleration of cases in the US or worldwide. And we really want to watch this deceleration phase very, very closely because it helps us prepare for the last phase, which is the preparation interval. And the preparation interval means that we brace for another wave of illness. And this preparation interval is really, really important. And it was a lesson that we learned from the hard way during the 1918 flu epidemic, the avian origin epidemic. Initially, with this 1918 flu, it was considered rarely fatal, and most people simply referred to it as the 3-day fever. So from March to July of 1918, people treated this influenza as no big deal. So practices that were put in place during the acceleration phase, the place where we see things go up and we start to do things to limit contact with people, was actually relaxed. So one of the main things that was relaxed during this is people celebrated the end of World War I, so that people were out in the streets, they were celebrating, they were happy that the war was over, unbeknownst to them, because now social distancing and restaurants and things had reopened to celebrate. The second wave hit, and it was from September to November, killing millions. And then there was a smaller third wave that occurred in January of 1919. So where we are right now in the acceleration phase is really important. As we start to see the cases go down, we really need to keep our eyes on this preparation phase so that we don't relax all of our steps we put in place to keep the curve flattened.
So Sharon, question for you. It's been asked by different infection preventionists here. So, when the case numbers start to decrease, right, should we be hopeful?
Well, I would say when case numbers start to decrease, yes, we should be hopeful, but we shouldn't ease up too much on social distancing. And even now with masking, we should still continue that. Based on the data that's been shared from China and Italy, we will still need to be cautious. Probably baby steps once we start to see the slowing down of cases. And we still, even now, need to look at the data coming out from China and Italy to see what happens once they hit those phases and they start to see their cases coming down. Will we have another wave of this virus? We don't know.
So essentially, we got to make sure that we take precaution, even if the case numbers are
hopeful.
Yep.
Always hopeful, but I think we still need to keep practices in place to prevent too much spread.
Totally makes sense. Thanks.
Okay, so the next slide shows the current spread in the US. And this is an epi curve. That's what infection preventionists and a lot of epidemiologists are used to looking at. This is data as of April 6th. And you can see the cases are still continuing to rise, which is not unusual because we are in the acceleration phase of this virus. So the current spread in the US, this is a map from the CDC website. It shows the US, and the map is actually from April 5th, but I've updated the numbers, not on the slide, but I do have the updated numbers. So as of April 7th, total confirmed cases are 386,821. So you can see they still have continued to climb quite a bit from April 5th. Total death is 12,299, and the fatality rate right now is at 3.2%. So things still keep percolating up. So we need to be watchful and keep our eyes on all the hot spots. The next slide shows the current spread worldwide. And this is a slide that was put together on database from April 5th. And the updated information from April 7th shows confirmed cases are at 1.3 million. Reported deaths are still around 75,000. And the fatality rate is still around 5.4%. But one thing to keep in mind when you're looking at this data is confirmed cases, reported deaths. There's a lot of misinformation out there where confirmed cases are cases that have been tested. And we know that testing in the US and as well as some places worldwide is either not happening or lagging behind. So I'm guessing that all of these numbers are probably higher than what we currently are able to report. And one thing to remember is, as a comparison, the 1918 influenza pandemic had a fatality rate of about 2.5%. And other influenzas are usually around 0.1%. So coronavirus is extraordinarily lethal. And we need to make sure that people understand that this virus kills and it doesn't care who or where. So how do we prevent the spread? Well, common sense would tell you the best way to prevent illness is to avoid being exposed to this virus. So we know some things about how this virus spreads, and it's thought mainly the spread from person to person. And they say that a cough or a sneeze, if you're within 6 feet of a person who's symptomatic, you have the possibility of getting these particles or droplets on you, which may potentially cause you to end up with COVID-19. Now, can someone spread the virus without being sick? Actually, the data shows anywhere between 18 and 25% of people can be asymptomatic carriers of this. Can they spread this? Yes, but the people that are the most contagious are those people that are actually symptomatic. So I think masking now, which has been sort of advised by the CDC and WHO, is a good thing for people when you're out in public to prevent coming in contact with those droplets. Now, contact with infected surfaces or objects. These objects and surfaces can be contaminated with the virus through coughing or sneezing. They may be a source of transmission, but they're not the only source. And that's why hand hygiene, cleaning and disinfection are so critically important. If your hands are clean and you happen to touch your face, your nose, or your mouth, chances are you won't contaminate yourself with this either through the droplet or coming in contact with objects or surfaces. So this little graphic demonstrates the volume of droplets that can be expelled during a cough or sneeze. These droplets, based on recent data, can remain suspended in the air up to 3 hours. And there was a recent study out that said it can travel up to 27 feet. All the more reason to enforce respiratory etiquette, hand hygiene, and masking, especially in symptomatic persons.
Yeah, talk about a visual, huh?
You do not want to get in front of that gentleman.
No.
So how do we prevent the spread? Hand hygiene. Hand hygiene has always been the #1 reason to prevent the spread and transmission of microorganisms. Clean your hands often. And the way you clean your hands, now they're recommending soap and water for every encounter, unless you're out and about and soap and water is not readily available. Then you would use hand sanitizer. So when you're washing your hands with soap and water, you want to wash your hands with soap and water for at least 20 seconds, especially if you've been in a public place or after blowing your nose, coughing, or sneezing. If you're out and about and there's no soap and water available, you need to use an alcohol hand rub that has 60% alcohol in it. Use that for about 15 seconds. Be very thorough, covering all the surfaces of your hands. Rub them together until they feel dry. Do not flick them or dry them with a paper towel. One thing about hand hygiene I want to emphasize is pay attention to the pads of your thumbs, the tops of your hands, wash up to your wrists, between your fingers and your fingernails. For those of you in a hospital healthcare environment, think of a surgical scrub and what that looks like, where you take the open palm of one hand and put your other hand in it and scrub those fingernails. We want you to think about doing a sort of a surgical scrub kind of approach to hand hygiene. I will tell you, I was the Ebola trainer for my former hospital. And when I trained the staff, I told them to perform hand hygiene as if their life depended on it. This is how you need to think now too. This is the #1 way to prevent transmission of this virus to you and your loved ones and patients. So remember, hand hygiene like your life is depending on it. And hand hygiene opportunities are always before and after any patient encounter, and before and after putting on and taking off any PPE, especially now in this day and age when we're actually forced to reuse PPE. So let's talk a little about cleaning and disinfection. There was this article in Morbidity and Mortality Weekly that showed that the RNA of the coronavirus causing COVID-19 was detected on surfaces of the cabins of the Diamond Princess cruise ship for more than 2 weeks after the ship had been vacated from the passengers. They found that they were able to determine that both symptomatic and asymptomatic passengers had the virus on surfaces up to 17 days later. So this virus will stick to surfaces and stay there for a very, very long time. Now, there was a study done on actual COVID-19 that showed it can survive on cardboard up to 24 hours, 72 hours on plastic and steel, and 4 hours on copper. The 72 hours on plastic and steel is probably the statistic that gives me the most pause. This is what most, if not all, of patient care equipment is composed of. So we need to get this right the first time when we clean and disinfect to help prevent transmissions to patients and staff. And we'll talk a little more about cleaning and disinfection. So what is cleaning? Well, cleaning is the process of removing unwanted substances such as dirt, infectious agents, and other impurities from an object or, say, a patient environment. You want to use water, detergents, soap, or enzymes, but the most important thing is mechanical action of scrubbing that object. Disinfection is the destruction or inhibition of growth of pathogenic organisms on the surface of something. Surface disinfection is a method to inactivate pathogens on inanimate surfaces. Usually they're hard, non-porous surfaces in a healthcare environment. So to disinfect a surface, the solution, that disinfectant, has to be able to touch the surface you're trying to disinfect. If that surface has debris on it, blood, body fluid, just plain dirt, the disinfectant is not going to be able to penetrate, so no disinfection will occur, or at least very limited disinfection. So I cannot emphasize enough the importance of cleaning first to remove bioburden, and then going back again and disinfecting that item. Remember, you need to follow all the manufacturer's directions for use of your surface disinfectant, including paying special attention to how you apply the product and the correct contact or dwell time. Cleaning needs to occur before disinfection can happen. So this pyramid is a good representation of how difficult it is to kill organisms with disinfectants. And if you look at the top, the prions are the most resistant, moving down to spores, mycobacteria, the non-enveloped viruses like norovirus, fungi like C. albicans, the gram-negatives, Salmonella and Pseudomonas, gram-positive bacteria, MRSA and VRE, and our enveloped viruses, which is where human coronaviruses fall. Fortunately, human coronaviruses, and we assume COVID-19, are also easily killed. So the EPA has a list called List N of EPA-approved hospital-grade disinfectants that are effective against COVID-19. These can be found on the CDC website, or you can simply Google List N. And what this list does is it provides you with the EPA-approved healthcare surface disinfectants you need to clean specifically for COVID-19.
Yeah, Sharon, I actually really like that slide because it kind of helps bring clarity a little bit to a lot of confusion or maybe fear that's really led by this pandemic, right? and being able
Right.
to understand, the different types of organisms and their resistance to disinfectants is really good. And of course, always following the recommendation. So just wanted to add that.
Right, great, thank you. So cleaning and disinfection. So in a healthcare environment, we should always be cleaning and disinfecting frequently touched surfaces daily. And it's the usual suspects. It's tray tables, doorknobs, light switches, countertops, handles, cell phones, keyboards, toilets, flush handles, faucets, sinks, you name it, and patient care equipment, especially shared patient care equipment. If surfaces are dirty, you have to clean them first. You can use a detergent or a soap and water prior to disinfection. But remember, and I can't say this enough, cleaning has to occur before we get disinfection. So the CDC has some specific guidelines for cleaning and disinfecting in a healthcare setting for COVID-19. You have to use the routine cleaning and disinfection products and procedures for EPA registered hospital grade disinfectants. We cannot get around to and use Lysol or Mr. Clean or anything like that unless it appears on list N. So the CDC says for COVID-19, you must specifically turn to list N for disinfectants for use against this SARS-CoV-2, which is COVID-19. I just want to reiterate that list N, the products that are EPA approved on list N are products that are effective against COVID-19. If your product is not on that list, you need to check with the EPA to make sure you can use that product for cleaning. Products that don't have a human coronavirus claim, you would look to the list to see if they have an emerging viral pathogens claim. If they don't have a human coronavirus claim, but they do have the emerging viral pathogens claim, that would be the product you would use, and you would follow the kill time listed for that. I know this can be very confusing, but list N is very, very specific about what you need to use and how you need to use it. And there's a lot of helpful resources on it. If you click around and open up the columns, they'll give you additional information if you have questions. If you're really in doubt, like I said, you can give them a call and talk to them about what the product is you're trying to use and whether it meets the EPA criteria. And just as an aside, in a healthcare environment, our standard of care should be all the time we clean healthcare environment and patient care equipment every time. This is how we prevent transmissions of organisms like MRSA, VRE, and MDROs, and especially important during COVID-19 pandemic. So a question people had was, what happens when I run out of a surface disinfectant at my facility?
Hey Sharon, I actually had, sorry, just really quick before we move away from list N, just because it's been a little bit confusing, right? So if you go back a slide for me, there are a lot of questions on contact times, right? There's a contact time for the emerging viral claim, but there's a different contact time for human, and then who knows however many other combinations there are, right? So just generally speaking, if a surface disinfectant has an emerging virus efficacy claim for 3 minutes and a human coronavirus claim for 1 minute, can we use the shortest dwell time? Like, what is the best practice here, given us wanting to follow, list N?
So according to list N, if it has a human coronavirus claim, you can use that dwell time or kill time. If it does not, you would look to see if it has an emerging viral pathogen claim, and then you would use that dwell time. So if you have a product that has 1 minute for human coronavirus and 3 minutes for emerging pathogen, you can absolutely use the 1 minute claim time.
Got it. Okay, fair enough.
I know it's really, really confusing. I had to read it several times to figure that out.
Yeah, and you had a really good point about that list N. I mean, you presented that to me yesterday, right? As we click through this stuff. So totally valid point on making sure we're clicking through all these hyperlinks. They are extensions of information. I know the EPA is doing their best to supply that.
Right, and I think they've done a really good job, because when you do click on those, they open up the column to explain what they mean in the header. So it's really good. Don't be afraid to click around, because you'll just get more information from it.
Yep, thanks.
Okay, so what is the contingency plan if I I can follow if my facility starts to run out of surface disinfectant. This is a really tricky one because healthcare facilities are mandated to use EPA registered hospital grade disinfectants. But we can do a theoretical, let's think outside of the box. I hope your facility never gets to this point, but we gave this some thought and we have a couple of suggestions you may consider. Again, healthcare facilities, don't try this at home. You probably would need to talk to your legal team or the EPA or somebody if you get to this point. So one of the things we thought about was see if there are comparable liquid ready-to-use surface disinfectants that are used somewhere else in your facility. For example, where I used to work, we used ready-to-use Cavicide. So it's still a disinfectant. It's probably on list N, and we might be able to figure out a way to take our ready-to-use liquid and train up our staff to be able to clean using a liquid and a microfiber cloth as opposed to having our available wipes on hand. So it's thinking a little creatively about the products you already have on site. So medical grade barriers were something I actually hadn't thought of in the hospital setting. I've seen them in the dental setting, but I'd never really thought about them in a hospital setting, frankly, because where I've always worked, they were always thought to be sort of cost prohibitive. But when you think about medical grade barriers for non-critical medical devices, it sure is a way to cut down on the need to clean and disinfect, for example, a computer screen or one of the wows that are used to collect patient information that go in and out of patient rooms. So maybe thinking creatively about where you could use a medical grade barrier when you're starting to run low on your surface disinfectants. So if surfaces are dirty, you can always clean using a detergent or soap and water prior to disinfection. And again, mechanical scrubbing is one really good way to reduce that bioburden, even if you don't use anything else. So push comes to shove, you're at least trying to reduce the bioburden. If you hit it with soap and water, you could probably reduce it even further. For disinfection, you can use a diluted household bleach solution, and the recipes for that are 100-fold on the web. You want to get probably a 1 to 10 solution. So you want to, there's a little formula here on how to mix up a small amount of solution. One thing to be aware of with bleach, especially in a hospital setting, is you want to stay away from topping off. And you also have to be careful to remember that bleach does not like metal. It can be corrosive. And there's a lot of medical equipment that you really can't clean with bleach because it may damage it. The other thing with bleach is you're really going to need to train your staff how to use bleach. Oftentimes a bleach solution right out of a bottle will leave a haze on a product, and you may end up having to wipe again with water to remove the haze. And lastly, bleach has a shelf life of 24 hours if stored appropriately. So it needs to be stored in an opaque container away from sunlight because that causes it to degrade. So although it seems like the next best go-to thing, there's a lot of caveats in handling that. So you need to be really, really careful if you end up having to go to a bleach solution. So for soft, porous surfaces, that's an even harder thing to clean because it is soft and porous. Mainly, you'd have to remove the visible contamination and clean with whatever the recommended cleaner is. If items can be laundered, that's your absolute best bet. You want to follow the manufacturer's instructions and usually try for the warmest appropriate water setting and then dry the items completely. Just remember, there are used products that are EPA approved against the virus that causes COVID-19. So the CDC has a lot of preparedness checklists. And what they say is that their general strategies to prevent the spread of COVID-19 in healthcare settings are the same strategies that you would use every day to detect and prevent the spread of other respiratory viruses. You know, healthcare facilities face outbreaks of organisms fairly routinely. We don't like to admit it, but we do. But we never see them on the scale of COVID-19. We deal routinely with MRSA, VREs, MDROs, C. diff. And the way we handle those outbreaks is we bed trace, we cohort, We clean and disinfect. We put visitor restrictions in place. We monitor our employees. These same processes apply to COVID-19, except you have to go bigger to be able to handle the volume of what it is you're seeing. So this checklist is a tool to develop a comprehensive, I say, everyday emergency response plan, and including COVID-19. You know, you always want to be able to have rapid identification and management of your ill residents. You want to figure out what you're going to do with your visitors and your consulting staff. You should always be assessing your supplies and resources. Your sick leave policy and other occupational health considerations should always be on your mind. Education and training should be ongoing. It should be annual. It should be written down competencies. And surge capacity for staffing, equipment, supplies, and post-mortem care is something you should be looking at the very least annually. So these steps should be reviewed annually because they can apply to basic preparedness. And we have COVID-19, this pandemic, but this won't be the last big thing. These same kinds of things you can do here can apply for hurricanes, tornadoes, snowstorms, power outages. Don't just be thinking about preparedness for COVID-19. Be thinking about how I can prepare my facility in general. What do I need to do to make sure I have all of these things handled for the whatever that may happen in the near future?
So Sharon, for this preparedness checklist, anything that you would say would be different and, you know, an alternate care site? I know, you know, eventually they'll start to reopen, right? Or, and I know this is also applicable for long-term care settings, but anything different that you would consider, or you think this checklist might also fit the need for alternate care or urgent care?
Yeah. Sorry, didn't mean to step on you. Yeah, I think it really does. It fits the bill for a general basic tool for how to plan a response to any emergent situation. And, you know, long-term care and skilled care are now being held to the same standard as regular acute care hospitals. So all of these things do apply, and they're doable. It's a smaller scale. There may be more moving parts, but I think it's really important to be able to create a plan that encompasses all of these elements of the checklist.
Yeah, absolutely. Okay.
So how do you prepare your facility as an IP? Well, the things I like to do, I like to stay informed. I like to get reliable, up-to-date information that's going on mainly in my community, but I also want to see what's going on in the rest of the world. So the place where I do that, the CDC website and my state and local health department. This time around with COVID-19, I have to give a huge shout out to the CDC for constantly updating their website, for constantly providing tools and checklists for acute care, long-term care, even independent living facilities. And I live in a 700-unit condo building. They actually put together a checklist for what we can do here too. So I think CDC deserves a lot of credit for actually being ready and pushing information out very, very quickly. So CDC is a really, really good resource. So you probably should develop or review your facility's emergency plan. I hope you have one. If you don't have one already, you may want to start to think about one. You know, and things to look at, an outbreak in your community could affect your staffing level. You know, what are you going to do for alternative staff? You want to know how to be able to call staff in if they're off and you need more people. So facilities, independent living, long-term care, acute care should always create and maintain an accurate emergency contact list. And again, you should establish relationships with key healthcare and public health partners. These are your resources. They are there to help you. They're an amazing group of dedicated healthcare professionals that will help you in any way they can. So partner up with these folks if you haven't already and get to know them. You know, I was a member of our hospital's emergency management committee, and I learned about a really great resource for emergency preparedness called the Incident Command System, which was developed by FEMA. Now the hospital version is called, now wait for it, the Hospital Incident Command System. Pretty clever. So what this does is defines the roles and responsibilities for key areas of your facility: operations, logistic, planning and administration, and finance. And then once these key areas are flushed out, people are assigned, key people actually are assigned to these roles to help keep your facility running. So in our facility, we had all of our VPs of security and supply chain and communications and the chief nurse and the director of the ED. All the key areas were part of this incident command system, and we practiced their roles and responsibilities so they would become comfortable with them. So if you don't already have this incident command system in place, I highly recommend that you at least look at it and consider trying it or stealing parts of it to help you keep your facility up and running, especially during an emergency like this. We use this for tabletops on biologic emergencies, radiation emergencies, surge capacity, bombings, terrorist threats, and all those things were emergency preparedness things that this incident command tool help us prepare for, and even biologics like this COVID-19. So think about it. It's a really great resource. Check it out. There's a lot of information about it on the web. Incident command system for hospitals. So the other things I think that are really, really important are to communicate with your staff and patients. So when you communicate with your staff, share your information about what you currently know about COVID-19, the potential for surge to your facility, and what your facility's level of preparedness is. Communicate with your patients, the same thing. Update your policies about appointments. You know, if there's elective surgeries and things, you may have to consider rescheduling those or canceling those. Tell the people that you provide care to that some things are going to change, and it's a rapidly evolving situation. So we will try and keep you up to date as much as possible. Be as transparent as possible to help prevent the spread of rumors and to tamp down fear. I believe that knowledge is power, and when you share what you know with your staff, you're sharing that power. Protect your workforce. Again, really, really important. How do you do that? You screen patients and visitors for symptoms of acute respiratory illness. And with COVID-19, we know they're fever, cough, and difficulty breathing. And you want to screen those patients before they enter your facility. So you want to keep up with the recommendations for preventing the spread of COVID-19 on the CDC website. As you all probably already know, things are changing just so quickly, it's almost hard to keep up. You need to ensure the proper use of personal protective equipment. Healthcare personnel who are in close contact with confirmed or possible PUIs should wear the appropriate personal protective equipment. If I was an IP, I'd be down there making sure that staff are wearing their PPE appropriately. In a situation like this, people are rushed, they're fatigued. Just to be there to provide some real-time coaching and guidance on how to wear the PPE could probably save people a lot of anguish later on and maybe prevent the spread of more contamination. You really need to conduct an inventory of available PPE, probably in this situation daily, because PPE is scarce. The PPE burn rate calculator, which is new on the CDC website, is a pretty cool tool. I recommend you check it out. The other thing is to really encourage sick employees to stay home. And we see this prior to COVID-19. We see this with the flu. Employees come in sick with the flu because they feel mostly okay. They have a cough or whatever, and they don't want to not come into work because they don't want to be dinged for this. So really look at your sick leave policy and make sure it's consistent with public health guidance and that it's humane to your employees. Consider addressing the reason why workers come to work sick. Maybe if you fix that, you can get more people to show up and you'll have less people showing up who actually are sick. And make sure staff know how to safely doff and store their PPE, especially because now it is being reused. I cannot tell you how important that is. That's the greatest source of self-contamination. putting used PPE on again. And how do you protect your patients? Well, again, you're going to stay up to date with what the CDC is recommending for all your patients, whether it's acute care, long-term care, residential living. Get a lot of great tools on the CDC website. You're going to separate patients with respiratory systems from patients who don't have respiratory systems. This is cohorting. We do this all the time. It's no different with COVID-19. The only difference is now there's an overwhelming number of these patients, and we're running out of designated spaces to cohort them. So you're going to need to think creatively. People have been using cafeterias. In the hospital I work at, there's a lot of little shops and things that have areas out front. There's conference centers. Any of those things can be changed to separate patients, the well from the sick. You might want to consider strategies to prevent patients who can be cared for at home from coming to your facility. And this is a great thing. Start calling those patients, calling finding out if they're symptomatic or asymptomatic. Be sure to guide them to when they should seek emergency care if their breathing becomes more labored or if their fever shoots up higher. And tell them where they can go for information about caring for someone in their home that has COVID-19. Again, CDC website has so many tools for acute care, long-term care, and just plain residences where people reside, apartments, condominiums, you name it. Facilities might want to consider adjusting their hours of operation to include telephone triage and follow-up on patients in the community. It's a lot easier to call someone than to ask someone to come in who may then contaminate your waiting room. And then telemedicine is a technology that's been out for quite a while, but in this instance of this pandemic, it has really moved to the forefront and is being used in a lot more instances. So think how you routinely handle influenza and then ramp it up to how you would handle this pandemic. And one thing I want to mention to long-term care facilities is be aware of your patients, because many elderly patients may not present with the typical symptoms. So you generally know your population. Be sure to look for anything unusual in a resident at your facility. It could be an atypical presentation of COVID-19. So I was asked what the top 3 protocols to follow during a pandemic are. And I will qualify this by saying this is really my opinion as an infection preventionist. I think staff and patient safety come first. So protocols regarding PPE use, specifically doffing by staff, would be number 1. This is so important because PPE is being reused. Staff need to know how to take this off, how to properly store it, and how to put it back on once it's been stored. Number 2 would be masking of symptomatic patients. This is kind of a no-brainer. They're clearly the source of additional transmissions. Masking them and somehow making sure they're compliant with masking is critical. I know you're probably all saying, yeah, we put the masks on them, but they take them off. So a lot of times it's education, so that they know if they don't want to protect themselves or you, then maybe they'll consider putting the mask on to protect the people that are around them. And then social distancing. This is tried and true. They did this in the 1918 influenza epidemic, and it worked. It helped flatten the curve and slow down transmissions. So I would also encourage social distancing in your facility. I know it's crowded with patients, it's crowded with staff. Staff could be doing everything correctly regarding PPE doffing and masking, but what they tend to do is they congregate together. They're in the break room together. They're hanging out in that one spot at the nurse's station together. Remind them that social distancing probably is not a bad practice to institute within the facility too. So the top 4 essentials for hospital functionality in time of a pandemic. Again, this is my opinion. A preparedness plan with at least the basics thought out and actually tested, not just a tabletop exercise. This is your hospital incident command system. We do tabletops and we do actual real deal exercises. It's really, really important to put a system like this in place, because it then forces you to go through an exercise and it helps you realize what your strengths are and what your weaknesses are. please take a look at this incident command system. I think it can really help you at least begin to put together a plan. Communication to everyone, staff, patients, visitors, vendors. People want to know, how are we doing? What do we have shortages of? When will the shortages end? The most frustrating thing for staff is to go into the clean supply room looking for X and it's no longer available and no one's told them. So communication is really, really important to the frontline staff and then to everyone else. Anything that involves the staff, staffing levels, supplies, food and drink, a place to rest, a place to shower, where can they get clean uniforms? These are all critical, critical needs. If we don't take care of the staff, there'll be no one to care for the patients. And now with COVID-19, we're starting to see that staff are afraid to go home. So there's lots we can do to help our staff on the front lines feel safer and better cared for. My probably number 4 is my biggest thing, training on PPE donning and doffing. This has never been thought to be important. People just always put it on and take it off. Now maybe it will be. Maybe we'll start to see annual hands-on training for PPE donning and doffing. When you do it correctly, it can save your life. If you don't do it correctly, you run the risk of contaminating yourself. And the CDC sequence for donning and doffing is really good. I like the WHO example, number 2, where you remove your gown and your gloves as a one-piece set. It makes it so much easier for staff, and it pretty much follows what staff actually do anyway.
So Sharon, I have a question for you. I have plenty of questions, right?
Yep.
When it comes to preventing the spread of COVID-19 in the hospital environment, what do you think is the most commonly overlooked area, and what measures can be taken to correct that oversight? And, oh, actually, no, it's your following slide. Yep, so the question still holds.
Okay, so I think, especially in a pandemic situation, the volume of patients and how quickly you need to move them from A to B probably makes cleaning and disinfection probably almost number 1 in my book. I think that people are rushed, they're trying to get things done, and you can't always clean and disinfect properly. And we know that this organism lives for up to 72 hours on plastic and steel. Mm-hmm. So we may do everything right for that patient, except now we put them in a wheelchair or in a cart that hasn't been thoroughly cleaned, and they touch something on the cart and they touch their face and now they've become infected. So I think cleaning and disinfection are really, really important. And hand hygiene, always and ever, for every possible scenario. Hand hygiene is really, really important, but not just the hand hygiene that you typically see when you're doing your auditing, where someone kind of hits that pump and sort of cleans their hands. This needs to be hand hygiene to save your life, because that's what it might do.
Mm-hmm. Yep.
Okay, so top commonly made errors throughout the healthcare setting in the midst of a pandemic. Now, again, this is my opinion. I have lots of opinions. So I think one of the things that I'm seeing now from my friends who work in the ED is that sometimes other people don't realize that the staff are scared and worried about bringing something home that could make their families sick. I actually was on the phone with a nurse who was scared to death because her 2 children are young. Her 65-year-old mother cares for her children, and her 65-year-old mother cares for her 90-year-old grandmother who has cancer. So, you know, we don't think of the staff as having lives outside of the hospital, but they actually do. So I think we're beginning to understand that now more with this pandemic. Recommendations are being made for caregivers in a healthcare setting to shower and change out of their uniform at that healthcare setting, bag up that stuff and bring it home in a bag. That way you're not contaminating your car and you're not contaminating your family, and you might even feel better leaving the facility being cleaner. The other thing that's happening here in Chicago is that the mayor has decided to offer hotel rooms for healthcare workers because they don't want to go home and risk getting their family sick. And I think that really came to the forefront when there was a little blip on the TV about a emergency room physician who had been sleeping in his car because he didn't want to go home and make his family sick. So I think we're finally understanding that the people who are providing the care are actually human beings and they have needs too. And I think it's great. So factor those kinds of things into your emergency preparedness plan.
Yeah, that's happening in California too, Sharon. It's great that people are starting to get involved and start to think about the staff, right? That's really caring for these patients. So we're seeing nationally for sure.
Yep. And when you think about the staff, I mean, a lot of them are young. A lot of them are just starting families, and they are scared to death to take this home, and then they have the responsibility of having someone in the family get sick or even die. That's a huge responsibility on your back, besides working a 12-hour shift at 100 miles an hour. So I think, you know, we're learning about these things in this pandemic, and it should be one of the top lessons learned about staffing. The other thing we talked about, improper cleaning due to time constraints. Cleaning is so important to prevent transmissions, to keep staff and patients safe. We need to make sure that we're not cutting corners on our cleaning. And then again, improper doffing and storage of PPE. In my years of being an IP, we never, ever said reuse your PPE unless it was an N95 dedicated to one patient, used for your entire shift, unless it's visibly soiled or wet. Well, now that is just out the window because we don't have enough PPE. So the guidance we're getting is, I guess, better than nothing, but staff need to be trained on how to take that off and how to store it and safely put it back on. So what websites do we look for when we need information on COVID-19? Your local health department is a great resource. They get a lot of information from the CDC, and they kind of pare it down to what's applicable for your community. APIC is a really good source for infection control information, and the WHO. And again, I can't say enough about CDC. They're my go-to resource. So I always look to them first. And when you look at all these other sites, all the CDC information is being trickled down to them and sort of reformatted to fit whatever the need is. So it's good, it's the same message, just being presented a little differently. So the last thing I have to say to all you healthcare workers out there is, please be diligent in hand hygiene, PPE donning and doffing. Keep yourself safe. You are so important. Thank you.
Thank you, Sharon, for going through that outbreak preparedness webinar with us. So just another note to add is just a humongous thank you to the health heroes that are in fact listening to this, right? You're taking the time out of your day to make sure that your facilities are well prepared and taken care of. And I would only hope that going through this webinar, you're able to get a little bit more clarification on, one, the current situation, right? And two, how to prepare, you know, your facility, your staff, your patients that come in for treatment. So thank you so much again, Sharon, for going through this presentation with us. I think you're going to go over one more slide, which is essentially what are some resources that people can leverage, right? Given this current situation beyond this webinar, right?
Right.
CDC and so on and so forth.
Yep. So this last slide speaks to some really great resources, and it's heavy on long-term care because long-term care has sort of traditionally been left to the wayside, but now the CDC is up to speed on long-term care. And the long-term care version is really taken from the acute care version. So all of these kinds of things also apply to acute care. They've just been changed a little and tweaked for long-term care. And the first one is a CDC YouTube webinar by Dr. Kara Jacobs-Slifka. It's a really good webinar about all of the ins and outs of COVID-19 and what nursing home and assisted living facilities need to do to prepare for COVID-19, PUIs, and positive patients, and also the movement of patients in and out of your facility. It's a very, very good webinar. I highly recommend it. And even acute care hospitals might get some good tips from it. The other thing, there's the 8-page planning checklist that we talked about, nursing home preparedness checklist. It's very, very similar to the acute care checklist. So please, if you're floundering in all the information, pull out the checklist. Not only does it give you boxes to check off to help you feel that you're doing the right thing, it gives you links to all kinds of other CDC guidance that are very, very helpful. Disinfectants, PPE, donning and doffing, signs and symptoms. It's a great, great checklist. And then there's strategies to prevent the spread of COVID-19 in long-term care facilities, as well as the same thing in acute care. And there's also letter templates to residents, families, friends, visitors, and volunteers for long-term care. And you can use those same letters if you need to get letters out to patients, family, and visitors to acute care. And another really cool thing that I mentioned earlier was they actually have guidance for retirement communities and independent living, which I think nobody really thinks about that. And it tells you what owners, operators, and administrators can do, and it provides checklists for those facilities too. And then there's the Federal Healthcare Resilience Task Force Alternate Care Sites Toolkit, which is another great toolkit for all alternate types of care. So CDC, there's so much on the website on COVID-19. I know it's overwhelming, but pick and choose and stick to something that would be simple and easy for you to follow. And I think it will help make your day a little easier, because a checklist is a great thing and they're easy to share and follow. So thank you again, and everybody be safe, okay?
Thank you so much, Sharon. Appreciate it. Echo what Sharon said. Be safe, everybody.